Hi there. What we're going to be doing today in this particular video is we're going to be demonstrating how to take vital signs appropriately per KVCC nursing program, and also how to measure SpO2. And after that, what we're going to be doing is the priority shift assessments, the foundation that you're going to be learning in the first semester, to be able to utilize in the clinical environment. So first of all, I just want to talk a little bit about vital signs. Remember, vital signs are vital to life. So anytime you have a change in your patient's condition, you should be checking the patient's vital signs. Remember, temperature measures the amount of heat produced at the cellular level. Pulse is measuring the perfusion of circulation throughout the arteries in the body. Respirations is measuring the amount of air that is carried into the vasculature and the exhaled carbon dioxide. And again, blood pressure is measuring the force that's created as the heart pumps its blood out into the vasculature. So it's very important, a very important measure of hemodynamic status. Remember that when you're taking temperature, and today I'm going to demonstrate, I have 4 mechanisms of measuring temperature on the patient that I have here today, which by the way is Monique Belize, and she is a recent graduate of our program who is now a registered nurse. So remember, the most accurate temperature is rectally. It's the warmest place. I'm going to talk about that in a moment. And remember, when you're measuring somebody's temperature, especially if it's orally, you want to make sure that they haven't drank or drunk anything really hot or icy or smoked a cigarette, because that will also increase the temperature. And exercise. Exercise increases heat production. Now, when we talk about blood pressure, there's a variety of ways that we can measure it. We can measure it traditionally brachially, right here over the brachial artery. We can also measure it radially. If for some particular reason the patient doesn't have any extremities, then we can certainly measure it over the popliteal area. And I've also seen it over the posterior tibial artery as well. Remember, when you're taking a blood pressure, the person should be seated. The person should have rested for a few moments. I don't know if you've ever heard of white glove syndrome, but sometimes we go to the doctor's office and we're stressed out and the first blood pressure they get is pretty high. So the patient should rest for a few moments before you take the blood pressure. Remember that when you're taking a blood pressure, the cuff needs to fit adequately. If it's too small, it will give you an erroneously high blood pressure. If the cuff is too big, it will give you an erroneously low blood pressure. Blood pressure has 2 measurements. It has a top systolic measure, which is the maximum amount of force that's exerted against the wall of the artery, and it has a relaxation point, or diastole, when the heart is relaxing to refill again and eject its blood. There's another component you'll learn more about later called mean arterial pressure. And mean arterial pressure is the average pressure of the blood in the arteries in between, right, when you're getting your systole and diastole, which is critical to maintain perfusion of all your organs. Depending on what book you read, your mean arterial pressure, which we don't calculate, it's done for you automatically on an automatic blood pressure cuff, is about 60 to 65. Greater than that means you have good perfusion. We're also going to teach you how to palpate a blood pressure before you take the patient's blood pressure, so that you can get a baseline blood pressure and know how high to pump it up. Remember, when you put a cuff over an artery, it's a tourniquet. It's obliterating all sound, so that when you hear the first sound thumping, it's your systolic, And then your diastolic is the absolute last sound that you hear. The other thing we're going to be doing is an SpO2 measurement. This measures the amount of oxygen that's circulating on your hemoglobin molecule. It's a gross measure. It's not as accurate as certainly an arterial blood gas, but it's a good measure. Normally what we teach students is that the SpO2 needs to be about 95, and that you need to report an SpO2 of under 90% immediately to your instructor or primary nurse. There are many things that can affect the SpO2, and that's peripheral circulation. So we need to check cap refill, see if the fingers are warm, check for a pulse, and that will increase the accuracy of the reading. Okay, so I'm going to get started this morning. I have my patient here, Monique. Again, remember, anytime that you access a patient, you're going to wash your hands, state your name, identify the patient, explain the procedure, provide privacy, etc. All right. So good morning, Monique. My name is Evie, and I'm going to be doing vital signs. Is that okay with you?
Good morning, Evie. Yes.
For safety purposes, could you give me your name and date of birth?
Sure. Monique Blau, and it's October 21st, 1990.
Thank you very much. Very good. That's correct. That's what I have with my paperwork. Very nice. Thank you kindly. So what I'm going to do first, and what you're going to do in the laboratory, because remember, vital sign competency is tested. And in order to be accurate with your vital signs, you need to make sure that your pulse is within 2 beats of the faculty member, up or down. The respiratory rate needs to be 2 beats, up or down, or 2 respirations, up or down. And the blood pressure needs to be within 4 millimeters of mercury. That's for the systolic and the diastolic, up or down. So what we have students do is they're going to write down, when you're being tested, your vitals. We write ours down, and then we compare after the fact. So there are many mechanisms to take temperature. Now, Monique hasn't had anything hot or cold to drink and hasn't been exercising. She's been sitting here resting. Again, what we're going to do is these electronic oral thermometers all have a clear protective cap. And you're going to place this under the tongue on the side and hold it for the patient because it is very heavy. Monique's temperature this morning is, Monique, is 98.2. 98.2 is normal. Oral, 98.6. Axillary, 97.6, the average normal. Rectally, 99.6. So this is a normal temperature. Now I'm going to take Monique's temperature another way. I'm going to take it tympanically in the ear. The tympanic membrane shares the blood flow with the hypothalamus. It's a pretty accurate measure. Oops, I wonder. Okay, so you have to turn it on. And then what you're going to do is, in order to straighten out the auditory canal, you have to, on an adult, pull up and back. On a child under the age of 3, down to straighten out the canal. So I'm going to put this in Monique's ear. Okay. And her temperature here is 98. So that is still considered normal. Now the last mechanism that I'm going to use on Monique is our temporal. And you can see now with the pandemic going on that they're using a lot of temporal thermometers, which is the best way because you don't really have to touch a patient. So with this one, you just place it, place it this way. Okay, Now, temporally, her temperature is 99.1. And again, it's supposed to be more accurate than orally. And temporally, remember, the normal, we always say temporal, tympanic kind of correlates with orally as far as a norm. But we always tell students 98.6 is the normal. A degree above or below is still considered within normal boundaries. So this is normal for Monique. Now, one way that I'm not going to demonstrate on Monique is the rectal thermometer. Rectally is the most accurate. And when you have a patient, especially that has a fever and they're breathing very heavily, you want to take it rectally. And again, when you're taking a rectal temperature, what you want to do is make the patient lay in bed on their left side. That gives you easier access of the thermometer to go into the lower rectal area. You only use a disposable rectal thermometer on the patient if they need a rectal. You don't use any other modality at all. You don't want to contaminate this. When you're doing your rectal thermometer, it is very important, okay, that you lubricate it. It goes into the rectum 3 or 4 inches, with gloves of course, 3 to 4 inches. You hold it until it rings. Don't let it go, okay? Because you don't want the whole thermometer going into the rectal area. It has happened in the past. So rectally, you will get a higher temperature, typically in the 99s, especially where hers was 98.2. And again, it needs to be cleansed, but that's another mechanism or a way to utilize temperature measurement. Okay, so the next thing I'm going to do is I'm going to take Monique's pulse, radial pulse. Remember, the normal range for radial pulse is 60 to 100 for the average age adult. Below 60 is bradycardia, above is 100. So when you're taking somebody's pulse, okay, the radial pulse is right here by the thumb. Don't use your thumb to palpate because that has quite a pulsation in it and it may alter your reading. What you're doing is you're feeling the pulsation with your 2 forefingers here. And what you want to do first is just find the pulse. And then once you find the pulse, you're going to count for 30 seconds and you're going to multiply by 2. If the pulse is irregular, you need to count for a full minute or listen to it apically directly over the heart. So I'm going to count now. Monique's pulse is 35. I'm going to multiply that by 2. That is 70. It falls within the normal range. It's regular. It's easy to palpate. And so that is normal. Now what you're going to do normally is not let go of the pulse. Some breathing action. Okay. And you're going to count respiration. 1 respiration equals 1 inhalation, 1 exhalation. So I'm going to count for 30 seconds again and multiply by 2. And when you're looking at somebody's respiratory rate, you want to make sure that it's not shallow, it's not deep, it's not tachypenic, it's not bradypenic. Bradypenic means under 12, tachypenic is over 20. And I usually just pretend that I'm still taking a pulse and then look at the chest. Monique's respiratory rate is 12. That falls within the normal guideline of 12 to 20. Now the next thing I'm going to do with Monique is I am going to take Monique's blood pressure. So typically we take it on the left arm, but I'm going to take it on the right arm. Now there's been some discussion about not crossing your legs when you have you're taking a blood pressure reading, because that apparently increases venous return. But the vascular studies indicate that that does not affect the blood pressure for a person that's sitting and has good vascular flow, but that's what you'll see in the textbooks. How's that? So the first thing I'm going to do is palpate her blood pressure. When you palpate a blood pressure, typically when a person's in crisis, you may only get the systolic or top reading. And when you palpate a blood pressure, you're only going to get the top reading, the maximum amount of force that is exerted against the wall of the artery. Systole. Remember, when you put this cuff on, it says here artery, and then inside it says this against the patient. So that way you'll get it in the right direction. The brachial artery is right here, right there on her. So I'm going to put it a couple of inches above. Make sure it's secure. Make sure it's not too big or too small. This is the sphygmomanometer, okay? And it has a valve on it. So you have to get used to just kind of releasing the valve appropriately, okay? So that it's not too fast or too slow. Because remember, this is like a tourniquet. You're inflating it to obliterate all sound, so you hear the systolic, the first reading, and then the last sound is diastolic. So I'm going to palpate first. So I'm going to palpate her radial pulse, and I'm going to watch the monitor here. I'm going to inflate the cuff. And when I no longer feel her blood pressure anymore, I'm going to let it go. I no longer felt it at 110. So I'm going to pump it 30 above. So I'm going to pump it up to 140. Okay? Now, why do we do this? So that we don't overinflate this tourniquet. Okay? Above 160, 180. It is uncomfortable and it hurts patients. Okay? So what I'm going to do now is I'm going to palpate her brachial artery. I'm going to take my stethoscope, which amplifies sound, and I'm going to place it over her brachial artery. Okay? Then what I'm going to do is I'm going to inflate the cuff. And remember, a manual cuff is calibrated in tenths. So each line beyond 120 is 122, 4, 6, 8, and then 130. All right. So I'm going to inflate the cuff. I'm going to deflate it until I hear the first sound. (102) over 74. So the first sound I heard was 102, loud pulsation, thump thump. And the last sound, the diastole, was 74. Now the new standard, according to American Heart Association, is that everybody's blood pressure on the planet that is an adult should be under 120 over 80. It used to be a little higher, but that's the new standard. As a student, you're going to look at trends in your vital signs. And again, if the blood pressure is under 100 systolic, you may want to assess what's going on. So if I had taken Monique's blood pressure and it was 180, and then I came back in the room and it was 90, that might be a bit of an issue where you're going to look and try to figure out what caused that to be altered. The last thing that I'm going to be doing on Monique is I'm going to be doing her SpO2 reading. This SpO2 monitor will also measure her pulse rate, but it's not as accurate as a telemetry monitor or a radial or apical pulse. So you're going to turn it on, and remember, most of them will show you, but there's a finger, right, where the finger goes. But what's going to happen is there's a light on the inside of this finger probe. The light needs to go over the nail bed. And again, her hands are cool a bit, but she's got good capillary refill. Acrylic nails might be a faux pas, especially if it's a really dark color, the light won't go through it. There are other ways that you can measure SpO2. You can also measure it on the earlobe, sometimes on the great toe. I'm going to measure it on her finger here. The light goes over her finger. What's happening is there's a beam that's bouncing down into her vasculature, and it's going to measure the percent of oxygen that's on her hemoglobin molecule. And Monique's perfect. Her SpO2 is 100%. And it's saying here that her heart rate is 75. Okay? Don't get these numbers mixed up, because clearly the SpO2 is on the left, the heart rate's on the right. 100%. Wow, I don't think I've ever got one that high. Beautiful. 100%. She's on room air. She's not on oxygen. And certainly, definitely within normal limits. So all of her vital signs are within normal limits. They need to be documented into the computer. You need to look for range changes, any big changes in her vitals. You want to try to figure out as a nurse why. The other vital sign that we teach students to do in the acute care environment is assess pain level, to see if the patient is having any pain. Are you having any pain anywhere today, Monique?
No.
So no. All right, well, that's good. All right, so that's the end of this component.